The following program is sponsored by Community Psychiatric Centers and is produced for educational purposes only. It is not intended as a substitute for medical or psychological advice, diagnosis, or treatment. The content should not be used for self-diagnosis or treatment of any health-related condition. As always, seek the advice of your healthcare provider with any questions regarding a medical or mental health condition.
Welcome to Community Psychiatric Centers Presents. Tonight we're talking about a topic that could save a life, and that life could be your child's. During the next half hour, we'll help you recognize the warning signs of childhood suicide and tell you what can be done to prevent it. But first, let's meet our experts. Dr. John Caruso is Clinical Director of Community Psychiatric Centers. He's a clinical licensed child psychologist and a certified school psychologist. And Dr. Robert Lowenstein is Medical Director of Community Psychiatric Centers. He's a board-certified child, adolescent, and adult psychiatrist and a fellow of the American Academy of Child and Adolescent Psychiatry. Good evening, gentlemen.
Good evening.
Dr. Lowenstein, first of all, how do you know if a child really is serious about suicide?
Well, first it's important to know that approximately 1 in 4 teenagers has at some time thought of committing suicide. So that's quite common. And it's very important to note that when they think about it or talk about it, it's important to take it quite seriously and not to basically ignore it. Younger children tend not to commit suicide or try to commit suicide as much as teenagers do. So it's less important in that population. But even in that population, it's important to take it seriously. The kinds of things that children do or say which can lead to possibly their committing suicide, they're called risk factors that we have to consider, can include a child making suicidal statements, sudden preoccupation with death or dying in conversations and writings or drawings. Sometimes these children will write stories that are quite depressing and sad. Some child, a teenager, begins to give away their belongings, is at risk for suicide. Again, they're preparing for their own death. Teenagers who suddenly become aggressive or hostile where they had not been before may also be considering a suicide. Running away from home is another risk factor. When not seen before, can be an indication that it's present. Risk-taking behavior, being reckless, is another sign. Using drugs, alcohol, or becoming sexually promiscuous is also a risk factor. Drug and alcohol abuse or the use of drugs and alcohol are very commonly seen in successful suicide attempts. Neglect of personal appearance, looking shabby, again, is a sign of depression and also possible suicide. And also, the more of these risk factors that are seen, the more is the threat more serious.
Dr. Caruso, it would seem that if a child is thinking of suicide, then they must be depressed. But how does a parent know if their child really is depressed to begin with?
Yeah, it's a good question, especially for kids. Most people are well acquainted with the traditional signs of depression. For example, a person appearing unhappy, a person being withdrawn, lacking in motivation, poor concentration. Now, kids may show those things, but typically quite differently than an adult might. For example, they may appear more irritated and agitated as opposed to sad. They actually may not be withdrawn, but when they are around other people, they may cause disruption, more behavior problems. They may seem to be somewhat motivated, but again, their motivation is more scattered and they have difficulty completing tasks. There's also usually sleep problems, appetite disturbance of some sort, either eating too much or eating too little. Very commonly with kids, you'll see somatic complaints, stomach problems, stomach aches. So those types of things are much more common in kids in terms of reflecting some sort of problem with their mood, namely depression.
Yeah. Dr. Lowenstein, in cases where a child is depressed and suicidal, does medication actually help, or, as some studies have suggested, can it actually cause a child to be suicidal?
Right. Well, the Food and Drug Administration has issued a warning to parents and to consumers in general about the risk of antidepressant medications possibly causing the presence of suicidal thinking and suicidal behavior. This has happened in very few numbers of people and children who are on these antidepressants. However, it is a risk factor which needs to be watched and considered, and when a child is placed on an antidepressant medication, particularly of the SSRI type, they need to be monitored closely for the presence of suicidal thinking. Sometimes a child who is placed on an antidepressant who formerly was fatigued and had no energy suddenly seems to cheer up, has more energy, seems more enthusiastic. At that point, that might be a sign the child has made the decision to commit suicide and therefore is more cheerful on that basis, and that also needs to be watched at that point.
Dr. Caruso, what should a parent do if a child starts making statements like, I wish I were dead, or, you know, I don't feel like going on? I mean, when do you take it very seriously?
We always take it seriously. You know, it's tough for a parent to hear their child saying something like that. And what you do with it or about it depends on the context in which you're hearing the statements. But again, you're always going to take it seriously. There's a tendency toward brushing those types of comments off, just brushing it aside, thinking, oh, they're not serious, and, you know, whatever the case may be. But again, it's important to consider, well, first off, the idea of when children say those types of things, typically they're in some way frustrated and having some problem that they're having trouble overcoming. So we want to monitor the child closely. At the same time, at some point after they calm, talking with them about, you know, what's going on, what was the issue at hand, and then giving them the coping strategies in order to get through the problem more effectively the next time. However, if there's any sense during this talk with the child that they have any genuine thoughts about hurting themselves, and of course immediately you have to get a consult, then what we would do then is work with the parent and the child to get a sense of how long they've had these types of thoughts and feelings, any plan of action that they may have toward hurting themselves. Again, it's rather rare for a younger child to act out in that way, but we'll assess various risk factors, as Lowenstein mentioned. Also keeping in mind that for kids, if they do act out in terms of hurting themselves, they typically do it quite differently than adults would. There's no cutting wrists or overdosing. It's more so possibly running into traffic or jumping off something high. And so those things sometimes aren't seen as suicidal behaviors, but again, it's something that we'll monitor.
There also are some important risk factor to consider, which we always consider, is prior suicide attempts.
Exactly.
If a child or an adult has made prior attempts at suicide that have been unsuccessful, and they're now at the point where they're feeling so guilty or so depressed or that they are again talking about suicide, that's a high risk factor. The other thing I wanted to mention about the antidepressants is it's very important when a person is put on an antidepressant that they stay on it long enough for it to work. Very often they start on the antidepressant and then stop it in mid-cycle, and then they regress, and that's a risk factor for suicide as well.
Are some kids really good at masking their feelings? I mean, you know, we talked about the signs, but are there some kids that can really keep it hidden so that you don't know that it's going to happen until it's just too late?
Absolutely, and those children often do slip through the cracks. Very often these are children whose parents also have been depressed. Depression can be inherited, it can occur in families, and the parents themselves may be somewhat depressed, maybe at a low level, and they're not able to appreciate the depression in their own child.
But there's almost always signs ahead of time, almost always.
All right, we're going to take a short break. We'll be back with more from our doctors right after this. You're watching Community Psychiatric Centers Presents on PCNC. If you have a question for the doctors, you can always call them for a phone consultation, 1-877-899-6500. Stay with us.
As a parent, you want your child to reach his or her full potential. For children with autism, early detection and treatment can make a world of difference in your child's life. At Community Psychiatric Centers, our autism unit is led by two highly trained and experienced mental health professionals, Dr. Robert Lowenstein and Dr. John Caruso. Their expertise in the field of autism spectrum disorders means you and your child will get individualized help you need every step of the way. Community Psychiatric Centers, connecting you, your community, your world, one family at a time. As a parent, you want what's best for your child. And that can mean asking for help if your child has problems at home, in the community, or at school. At community psychiatric centers, our highly trained professional staff offers mental health diagnosis, treatment, and therapy to your child in their natural environment, at home, at school, in the community, or at one of our 11 southwestern Pennsylvania locations. One phone call can change a life. Community Psychiatric Centers, connecting you, your community, your world, one family at a time.
Back to Community Psychiatric Centers Presents. We're talking with Dr. Robert Lowenstein and Dr. John Caruso of Community Psychiatric Centers about ways to prevent childhood suicides. And Dr. Lowenstein, what should a person do if a child, say a nephew or a niece, comes to them and says they are considering suicide?
Right. Well, the most important thing is not to blow it off, not to assume that the child's just talking about it and they may not be serious, not to discredit it in any way. It's important for that person not to tell the child or the teenager that they've got so much to live for and why they're depressed, that kind of thing. Try to undermine that child's self-confidence and try to undermine their feelings, which are quite intense. If someone confides in you as a parent or a relative or a friend that they're thinking of suicide, it's important to first ask them if they have a plan of how they're going to carry it out, if they've tried to carry it out in the past, if things are in place for them to do so, if they have the presence of guns or some weapon which can make suicide a lot more serious. Those are very important things. At that point, it's important then to notify someone to help the child. It's important for them to be evaluated by a psychiatrist or psychologist, to get into treatment, sometimes be hospitalized to prevent the suicide from happening and be treated appropriately in a safe environment until those feelings go away. In most instances, people that are acutely suicidal today, after a short period of time, no longer are suicide, meaning those feelings don't last, and once in treatment, they can be saved.
Dr. Caruso, Dr. Lowenstein had mentioned hospitalization. What would require a child to be hospitalized? What kind of situation would set that up?
Well, the bottom line criteria is if the child is a danger to themselves or others. That's really the criteria that's used, although it's not always easy to assess that. All of the factors that Dr. Lowenstein mentioned at the outset of our program today would be considered when determining whether a child needs to be hospitalized or not. It really is the last resort. If a parent feels the need for their child to be in a safe environment, such as a hospital, there's different ways of accomplishing that. They may, if the child's emotional and distraught, they may decide to call 911 and have the child transported by an ambulance or a police officer, or they could transport the child themselves. Once there, well, also keeping in mind that counties have their own crisis numbers set up for mobile crisis units to come to the home or do de-escalation over the phone. If a parent wants to know what their crisis number is for their county, they can give us a call and we can provide that for them, or they can call their county BS service unit. There's also a national number, a 1-800-SUICIDE is a 24/7 number that's available for parents as a resource.
Right. It's important also when you suspect that a child is suicidal, talk to them about it. You know, there's a misconception that if you bring it up, it makes the person even more suicidal and put thoughts in their head. That's not the case. The reverse happens. If you bring it up, you show them that you care, you show them that you understand, that you're supportive, that someone is there that understands what they're going through. It helps reduce the risk greatly. If
a child is hospitalized, just to follow up on one last point, it's vitally important to work very closely with the treatment team as a parent, the hospital treatment team, and make sure that the child is discharged with a very, very clear and specified discharge plan so that the parent knows precisely who they're seeing, when they're seeing that person for a follow-up outpatient session or a partial program, wherever they're going to. It's very important that's very clear and specified.
I'm always interested in the time period. Is it really a short time period between someone thinking of committing suicide and actually doing it?
It happens in all different ways. Sometimes drugs and alcohol play a role in that. If someone is chronically depressed or even acutely depressed and they get drunk, or they use drugs which help to diminish their inhibitions, they may then act out on that suicidal thought at that moment because of the influence of drugs or alcohol in their system. Other times, people can be chronically suicidal and not act upon it unless something happens that seems to precipitate it in their life. They suddenly lose a girlfriend or boyfriend, fail at school, fail at job, and that seems to tip the scale.
So what type of therapy is actually available for these children and for their parents?
Well, at community psychiatric centers, we will engage these children and teenagers in individual counseling. We'll engage the family in the treatment process. We will clearly try to establish a contract between the child and the treatment team, so as to what to do when they feel suicidal. We hope that they contract not to act on their suicidal feelings and tell them in that contract what they can do to seek help when they're feeling that way, and have a good team around them that can support them through the process. We'll also treat them with medications appropriately for a long enough period of time so that it works.
And so just the importance of parents using our phone consultation option, of giving us a call and talking about any concerns that they have. We have very specific protocols for children who are depressed to address those issues using any number of treatments, interpersonal therapies, cognitive behavioral therapies. These interventions are proven in research to be very, very effective, and so help us out there. It's just a matter of seeking it out.
It's going to be really rewarding if you can intervene at the time that's really critical.
At the time and ongoing, because typically this is part of a depressive episode that can be on and off for the course of months, and so the idea of turning that around and helping a child to feel more happy and confident is definitely rewarding.
Treatment has to be ongoing. A child can be hospitalized, treated for depression, come out and still suicide, even with the treatment having gone on in the hospital setting. So it's important to have good follow-up and close monitoring of that child.
Take a short break. We'll be back with more questions for our doctors right after this. Remember, if you have a question or need more information, you can always log on to their website, cpcwecare.com. Stay with us.
Do you have a child, adolescent, or teenager who is having trouble at home, in the community, or at school? Call Community Psychiatric Centers for help.
I work as a licensed psychologist and certified school psychologist. My partner, Dr. Lowenstein, he's a board-certified child psychiatrist. Together, along with our professional staff at CPC, we're prepared to meet any family mental health need when they need it most.
When a child is in crisis, when a child is suffering, when a child is in pain, a family is in pain and a family suffers. And our goal is to relieve that pain and find the child where they are and help the family to heal. And that's the basis of our program, is to help families to heal.
For a free phone consultation, call Community Psychiatric Centers today at 1-877-899-6500 and watch Community Psychiatric Centers Presents, Wednesdays at 7:30 on PCNC. Community Psychiatric Centers, connecting you, your community, your world, one family at a time.
Welcome back to Community Psychiatric Centers Presents. We're talking with Dr. John Caruso and Dr. Robert Lowenstein about preventing childhood suicide. And Dr. Lowenstein, you talked earlier about medication management for the treatment of depression. What are some of the most commonly prescribed medications, and what are they, how effective, and what are some of the side effects?
Well, there are a great number of treatments of depression. There are many of medications that are currently used that have been used for a number of years, and then there are some of the newer ones that are out which are very effective. Basically, the ones that are treated for the use of depression these days are the SSRIs, most commonly, but there are other medications as well that have a long history of help for children. Side effects for these medications can vary, but they can include things like upset stomach, nausea, vomiting, weight loss or weight gain, problems with sedation, and of course we have to monitor them for the presence of suicidal feelings as well.
What do those SSRIs do? How do they stop?
Well, they basically help replace a neurotransmitter in the brain which is not there in sufficient quantities in those parts of the brain which affect a person's mood.
All right. Dr. Lowenstein, one more question about new research on expectant mothers and antidepressants.
Yes, there's a new study that was published in a British Journal of Psychiatry which helps to allay some fears regarding the use of antidepressants in pregnant mothers during the first trimester. It has been thought in the past that a good number of these medications could have caused some of the birth defects that children can have with the use of medications. But apparently the study done with 2,300 parents who were pregnant showed that there wasn't much of a risk in the first trimester with the use of these medications. Of course, this has to be taken with a grain of salt, and expectant mothers need to consult with their obstetricians about this.
All right. Dr. Caruso, we were talking earlier off air about the importance of data collection in the treatment of depressed children. What exactly does that mean, and how can parents benefit from this?
Yeah, sure. It's something we've talked about in past shows as well. Data collection is simply a term that refers to the tracking of behavior or mood. On one level, we can look at it as tracking, for example, how often something happens, whether it be tantrums or non-compliance, and knowing that is vitally important so that we can get a sense of progress over the course of time. For a depressed child, we may track their mood using various mood protocols, so we can get a sense of how severe their mood is depressed, for example, at the outset of treatment, and then monitor it over the course of time. How else are you going to know how progress is coming along? It's important for parents to be on board with this. If a parent has a child with behavioral, emotional, or developmental issues, it's vital that they are involved in the treatment process and also involved in data collection, which could be as simple as something like a sticker chart for some young child with behavior problems. It's very difficult to look back 3 months ago compared to now and think, okay, well, has there been improvements? Where are we at now compared to a month ago, 2 months ago, 3 weeks ago? It's hard to remember what happened yesterday, let alone down the line. So the idea of having data collection in this whole process is very important. And any treatment team a parent's working with should be heavily involved in data collection. If they're not, there's a problem, because that's instrumental.
Dr. Lowenstein, we've talked in past shows about the importance of and the value of family meetings. Does that hold true also for depressed children and their families?
Oh, absolutely. It's important to have the family closely participating in the treatment of their child. We do that on a routine basis. You cannot treat a child in a vacuum. Family is very important to the welfare and the well-being of the child, and often it can do a great deal to improve the situation with the child. It's important that the parents understand what positive things they can do and also what things they need to avoid.
And, another aspect of family meetings is the idea of families meeting themselves on a weekly basis, and it helps to improve cohesion and communication, where the family meets. It could be informal or formal. You actually take minutes if you wanted to, but the idea of talking about family vacations, upcoming family nights, chores and chore rotations, and problems and concerns. It's a wonderful thing that we highly recommend for families to get involved in.
We probably don't even realize how much we don't talk and communicate.
Definitely.
Computers and everything, TV.
Absolutely.
All right, we're going to take a short break. We'll be back with some of your email questions right after this. Stay with us.
Is your child defiant at home?
Do teachers say your child refuses to behave?
If this sounds familiar and your family is in crisis, we can help. I'm Dr. Robert Lowenstein.
And I'm Dr. John Caruso.
At Community Psychiatric Centers, we make it our mission to quickly and effectively diagnose and treat your child so your family doesn't have to spend months on a waiting list.
Call us today for a free phone consultation. An early diagnosis and proper treatment can make a world of difference in your child's life.
Have you noticed something different about your child lately? Does your child seem withdrawn, unhappy, depressed, or prone to sudden outbursts? Your child may be suffering from a mood disorder, and it may be time to get help. At Community Psychiatric Centers, Dr. Robert Lowenstein and Dr. John Caruso lead a highly trained professional staff that offers mental health diagnosis, treatment, and therapy to children and adolescents. Call 1-877-899-6500 today for a free phone consultation.
Welcome back to Community Psychiatric Centers presents a few final questions for our doctors, and they are email questions tonight. First question, my 8-year-old child has tantrums and he'll scream and yell. During those times, sometimes he'll say he wishes he was dead. I'm obviously concerned and I don't know what to do. How much should I be concerned?
Obviously, it's important to know your child, and sometimes a child will say they wish they were dead in a fit of anger or in an attempt to manipulate their parent, and if that's the situation, then the parent needs to take that into account. But obviously, if the parent is concerned that the child might act out on it, if they have other signs of depression that we talked about earlier, then clearly they need to be evaluated.
All right, here's the next email question. I have been using a sticker chart for my 5-year-old. I target not hitting his sister, picking up his toys, sitting for dinner, not tantruming, and no back talk. I give him a reward for earning the stickers once per week on Friday. It does not seem to be working too well. Any suggestions?
Well, first I'm going to commend the parent for doing the sticker chart. You know, most parents don't, and they could, and they probably need to, and oftentimes it is very helpful. But you know, sticker charts, is as simple as they may seem, can be a little complex, and there are some things to keep in mind. So when things like this happen, it calls for a consult. One thing that we would say to this parent is maybe they're tracking too many behaviors at one time. 5 can be a bit much, maybe 2 or 3. Start simple, start small. Also, for a 5-year-old, we may talk about increasing the reinforcement ratio in terms of providing the reinforcement more often. Once on Friday for a 5-year-old, that's just way off from them. Thinking from Monday to Friday for them is like thinking for us, like end of the year type of thing. And so it's difficult for it to have much of an effect when the reinforcement's that far away.
So these
it's also important to know whether or not the choice of the reinforcement works. Maybe a sticker chart doesn't mean anything to the child. Maybe the child's ability to watch TV or get an ice cream is more important, in which case the parent has to change whatever they're using as a positive reinforcer.
Let me ask you a question about the sticker chart. How does this work? If they do a positive behavior, they get a sticker? Or if
usually we stick positively and word them positively. So if the child accomplishes something that they're supposed to accomplish, they pick up their toys or be nice to their sister, then they do that for X period of time, they get a sticker. And so end of the week, you add up the stickers, and if you have a certain number of stickers, then you get the reward. But it could be done, and probably for this child even better, to be done daily. Add the stickers up daily. At the end of each day, there's a little extra reward that they get.
All right. Another email. I was raised by parents who were not very affectionate. I was not hugged much and never told that I was loved. Now I find it hard to show that type of affection to my child, but I know I need to. What do you recommend?
Well, I think it's very interesting that this parent is able to recognize something within themselves that they want to correct. That's the first step in correcting things. They need to perhaps be taught how to be more affectionate. There are various ways to do that. They might even enter into counseling themselves in a way to help them open up to their child better.
And to break those patterns, the idea of starting small, simple, forcing themselves to get out of their comfort zone, saying I love you to their child is something that they can do. It may be uncomfortable, but in a few weeks it won't be uncomfortable anymore. We also offer, as Dr. Lowenstein mentioned, experiential types of approaches where we will walk a parent through a parenting process which involves showing of affection. And sometimes parents who have had really difficult childhoods really need, walk through the process of being an effective parent.
Because sometimes if you're saying to somebody, be more affectionate, and they don't know what affectionate is.
Exactly.
Absolutely.
Exactly.
Yeah.
Yes. And so, but again, even a parent such as this can give a hug before going to work in the morning and can say, I love you. Typically, a parent can pull that off, even though it feels very uncomfortable at first. Within a few weeks, usually it becomes much more comfortable.
All right. Thanks so much for being with us. And thank you for watching. We'll see you again next week. Have a nice night.
As a parent, you want your child to reach his or her full potential. For children with autism, early detection and treatment can make a world of difference in your child's life. At Community Psychiatric Centers, our autism unit is led by 2 highly trained and experienced mental health professionals, Dr. Robert Lowenstein and Dr. John Caruso. Their expertise in the field of autism spectrum disorders means you and your child will get individualized help you need every step of the way. Community Psychiatric Centers, connecting you, your community, your world, one family at a time.